Thank you so much, leaders, for joining us on another episode at Dawdle.live. And today I've got Dr. Dina Shah with us, and she's going to talk about a lot of interesting stuff, which is of an interest to a lot of corporates who will be watching this show as well. But before we go to the topics, would like to give a formal introduction about ma'am. She's a distinguished emergency medicine leader with over 2 decades of experience in building and leading critical care and emergency response system across leading healthcare associations institutions. She is currently founder director at Viznair Emergency Care Services, where she focuses on advancing emergency care standards, training, and system development in India. Previously, she was director of emergency medicines at Fortis Hospitals, where she played a pivotal role in establishing and scaling emergency departments while also chairing specialty councils. Her experience spans clinical leadership, academic roles, and capability building, including her tenure at CMC Vellore. She's known for her expertise in emergency care delivery, training, and healthcare system design, and she continues to drive impactful improvements in patient outcomes and emergency response readiness. Thank you so much, ma'am, for joining us on this podcast.
That's very kind introduction. Thank you, Rishikesh.
Thank you so much, ma'am. Ma'am, the first thing, I think it's quite of an interest to a lot of individuals who will be watching it is that if we talk about India, across India, especially beyond metro cities, what do you see the most critical breakdowns in emergency response systems today?
Most critical breakdown in the response of emergency in our country is at the site. So at the site when something happens, there is
Yes.
nobody to give the first aid. We call that as a first 10 minutes of platinum minutes, it is called. And there is no a first aid provider in our country. We don't have that kind of training in schools and colleges, which gives an opportunity to the people to respond to any emergency if they see, be it a home or be it on the road. So that's the first breakdown in emergency care services in India.
First 10 minutes. And I think, ma'am,
Platinum minutes.
platinum minutes. I think you also call it to be, okay, we'll come to the golden hour problem later. So, if you had to prioritize, ma'am, like which gaps are costing the most lives and why do they persist?
In our country, the structure is not there. Now, when there is no structure, the response is going to be haywire. Then we feel that it was not going to happen, so it didn't happen, and kind of stuff. But if we develop a structure around it, example, if we train all traffic police, every public, whosoever is undergoing their graduation, they should have a first aid trainings before they graduate, and that way it will give an window of opportunity to look into what will I do instead of panicking and wasting and calling for help or crying and running with a person here and there. So those things can be avoided, first thing, by the public response or the civilian response. Then comes the clinic response. People will take them to the clinic nearby without knowing whether they can provide those services. Example, if somebody had a stroke on the road or in the car or at home, they would go to their general practitioner, wait for them without knowing the time is crucial, and they miss the opportunity to survive the brain cell to the max, and that's where it matters. The third part I would like to add is to give the treatment as a first aid responder. Example, in case of trauma, at least stop the bleeding. So trauma, majority of the patient dies because of the bleeding, and that's where it suffers. These things, if we develop and we look into as a coordinated, structured response, we can do a lot better and save more life and limbs.
That is so true, ma'am, because I think, like, this has been kind of talked about for a very long time. Like, while I was in my college, like, 13, 14 years back, there was a training program that happened, like, how to provide CPR to people. But it was never taken that kind of a seriously, especially in India. Like, because I don't know why, because traffic police, you rightly mentioned, they don't know the basics of the first aid. Then even the police, they don't know. Even there- there's a total lack of kind of awareness. So I was talking to my mother, I think 3 months back, and I told, why not you guys learn how to provide CPR? And she was like, why should I learn? So there's a complete lack of awareness in India. But on the other hand, if you compare the other geographies, ma'am, I see the response time is pretty fast. Like within, like even the airports, even the schools, even the colleges have got facilities for providing CPR. And why I'm talking about CPR, because that is something that comes to my mind when I talk about emergency response. But in India, I kind of seldom see. I have seen some malls kind of, having this kind of a facility. So why in not to following the process is our culture. So if they ask us to put a seat belt, see the police and we try to put a seat belt somehow, or we argue and we go away. We don't wear the helmet. Helmets are hanging in the hands or engineering helmets. So and then so basically it's taking the life too lightly. That's the way I can, that's the only way I can answer. Very difficult to say why people are not. But on other side, from 2010 till now, it has shifted a lot. So you will see the structured AD, airport staff trained, train staff, train stations, train has got all those facilities. All those major offices, corporates have got those facilities, malls have got those facilities. So slowly it is coming into the as a law and rule, a ruling thing that you have to have certain things if you are collecting so many people under one roof. And that's the only way we can put it in the blood for the people. Yeah, right. Ma'am, we often hear about the importance of the golden hour. So if you're elderly at home, or some people at home who suddenly cannot speak, or just cannot move the hand, and then what happens? They take them to the nearby doctor or to their GP. They wait for them. So all first 10-15 minutes are what is happening, why it is happening, happens at home. So first 10 minutes gone, then taking them into the car or auto, taking them to the GP, another 20 minutes gone by the time GP decide to shift the person to the tertiary care center who can provide them the stroke care. Then they don't confirm whether the CT is working, MRI is working, neurologist available, all those things without confirmation. They shift and patient arrives in emergency. Now emergency also has got a bit of a loose structure where the tying the notes are very difficult. Very few hospital has got that quick response of stroke because they have put a structure around it. And then the time get wasted again. So almost first hour is gone. While when we talk about the American Heart Association stroke protocol, which is there since long, 2008, it is there, or it has been introduced long ago. And those are saying that you have to be in the hospital as soon as possible. Call an ambulance and go. So ambulance can assess you, warn the hospital you are coming, and then you reach the hospital where hospital is ready to receive you, give you the treatment and all, and you get the needle or the intervention therapy from intervention procedure by the neurosurgeon. So neurologist or neurosurgeon, depending on the need, would they find out from the CT and MRI, they can be treated. If they get this treatment clearly, they can have a reversible outcome in 48 hours. So that's beauty of the structured response, which we are lacking. It's not now zero. It is in major cities, major hospital corporates. All are very well geared up with the help of JCI and an NABH ruling there, with the performance indicators get measured and all those things. But it is not percolated down to the second tier and third tier cities. So that's where we are lacking. And it can be done provided somebody puts the structure in place, and then patient can be shifted. So all those things can be learned in the first aid by the society as a layperson, and they can actually save the life or limb or brain or heart. All these regulatory authorities are there. There are standards in place, although I would say that the standards are still not at mark as what it is there inside the US or some other geographies. But why is that execute the structure that follow the NABH and JCI? NABH and JCI comes to your hospital, give you the identity that you are a stroke responding hospital, or
cardiac hospital, they give you the their certificate that you, yes, they have checked everything and all. Now, if the hospital missing out on those things, then what? That is not structured. Then how people are reaching to those services are not structured. How, like, if I ask you right now, what is the nearby hospital where you are? Is stroke identified hospital? You don't know. Yeah, so they are not identified in the community, they are not decorated, that these are like cardiac is long time, so you know many hospital who are doing only cardiac, and they can respond better for cardiac, but not for the stroke and other trauma and all, where building all the highways and lots of highways, now we are seeing increasing number of accidents. So those structure needs to be built. There are trauma center which are tertiary care, but then primary care and secondary care needs to push it to the tertiary care on time with coordinated action. Then only it can work better. And in this, the public, the EMS means ambulance services, and the first responder in the hospital matters the most. If these three structures are in place, it can, then only it can be done. So there are many things are involved in this response, and that's why somewhere or other it keep breaking down. And sometimes it works beautifully. I've seen people coming to us in Fortis, and they walk back home with a big, beat trauma, be it a cardiac event or arrested condition, electrocuted, stroke. All those people go back home and live their normal life. It can happen because it's not the karma was nice or my day was nice and everything all stars align, and then we say if not, oh my, that's fine. But instead of putting it to the spiritual context, we should try and work it out as a community to the medical fraternity. That gap needs to be built. If we blame the government has done this part. Now it is a responsibility of those regulatory authority, hospital, and the community to take it on. That's what I believe. Yes.
Absolutely, ma'am. And the awareness has to start from the grassroots level. Ma'am, also, we see a lot of hospitals invest in infrastructure. We see 5-star hospitals now, even 7-star hospitals now, but outcomes don't always improve kind of proportionally.
We have got a 5-star, 7-star hospitals with big specialist available, very good infrastructure with all the equipments to diagnose, investigate and treat are available. Robotic, we have reached to the robotic treatment as well. Where is the gap? The gap is not at the getting the infrastructure level. Gap is not at the providing level. Gap is in coordinating the thing. And that coordination needs to be done at the hospital level. And hospital has to put it in the surrounding community that, yes, we are there for you. And the surrounding community should know. That is the first part. Second part, in our country, we are still lacking in the terms of medical insurance. And that's where people avoid going to the major corporate thinking that they're expensive and I can't afford and I go to some other level. And then they fall into the trap. Or in government hospitals who are really good structured, good specialists are there. But the waiting time and approaching the specialist is very tough there. So if the structure will put in the place, it can be happen. Yes, the third part, what you said, is a coordinated approach will help to improvise on the, this kind of care.
And also, ma'am, we see most of the workplaces also view emergency preparedness as just kind of a compliance driven. And in India, it's very common.
And mining industry, whatever industry or organization or the simple office you are talking about, first thing is to map the risk. First thing, what are the risks? Electrocution, fire, all those basic you have to do, and basic first aid needs to be structured. So early response team should be there, which includes your lift, your fire, and your electricity, and your first aid. So all four members who are trained and they can reach to the site and provide that care to the people. Then comes any major incident or any major disaster, be it an earthquake or be it a major fire or structure collapse, all those things. So how to retrieve, whom to approach, how to save maximum life, all those things needs to be practiced. So map the risk and then plan the disaster response and then practice. Then all employees should know where to collect. Like there's a board everywhere. This is the, you can gather here in a case of emergency, but how do I reach through that place and what all I can do, whether the ramps are there, because the staircase sometimes collapse and lift you can't use, so how you're going to go down, all those things needs to be mapped. And then it's like more of a assess the risk and then plan the response. With a heart attack in the office during work, they got the authority saying that every person working in our office should be trained with a CPR. Because something happened, they were all listening, they were all ready to practice. I go to schools and colleges and offices, but they come with a cup of coffee and with the earpods and all. And then there is no that seriousness that when am I going to have this CPR done, why should I learn. So sometimes I have to shake them up that, and then they ask why you teach this free of cost. And I'm like, oh, you are the first responder for me, so if I don't teach you, how am I going to survive? So you have to remember, it is not for you, it is for somebody else. So, sorry, it's for you, not for somebody else. You are learning for you. So you go home and teach your family so they can save you and you can save them. Because if that much response you learn and be alert in learning, you can do wonders. And I have seen the examples in certain companies where I go back all the time, and they have saved the lives on Paharganj railway station, in Terminal 3 airport, by themselves, by attending just the training I gave. Because I'm doing it since 2010, so long journey. And that's why I get the feedback that this small training is very effective. We store this in our small brain and it pops out at the time of need. So we have to have this tool in our kitty so we can respond.
Yes, that is so well said, ma'am. Because I think if this thing was done right, we can save a lot of lives all around us, and also by this way we'll make a better society as well. Because people know that there are people to take care of them, maybe in their society, on the roads, in their school, inside the colleges, inside the corporate houses.
Who will take me to the hospital? Is that the hospital come and collect me, or the people on site will take me, or I will have the ambulance coming to me from somewhere and taking me? We have got lots of opportunity. We are the only country who doesn't have a restriction in healthcare. You can reach anywhere, any type of ambulance can reach you as well. We've got now bike ambulance, three-wheeler, we've got various ambulances, like people have built in the villages, the bullock cart and camel cart, and they are trained as well, so they can take them to the nearby area. We've seen that as well. So building a structure, training, but that thought should be there. Right now, we are thinking that we are unbreakable, unshattered. No, we cannot get shattered. We cannot fall sick. It is not coming in our mind that we have to be ready, like war ready, like disaster ready, earthquake ready. We have eventually built a structure in the building, that building don't collapse because of the earthquake, because we are on earthquake seismic zone. So it is like that. So first, we are human, so we are going to have either heart attack or stroke or trauma or any other things, epilepsy or any other things. And heat stroke, like if you're going on the heat area, desert area, or you are going in the cold area, like northern area or Norway kind of thing, you have to be ready. We are ready with our jackets and summer, then cooling clothes, and we get ready for all those things. The same way, we have to be ready for responding to all this emergency where your loved one are going to suffer. And that's the only way we can improvise on the emergency care and be emergency ready. So I would As I said at the beginning, I would repeat that we have to put it in the school. What I have seen in other country is from standard 7 or 8, every year they have to go through one lesson of first aid every year. So by the time they become health or graduates, they are emergency ready. That's the easiest way to do. The school teachers, the children, if we build the children, they will build the community. And once you teach one
Yes.
child, they teach 4 people for you. Mother, father, nana, nani, dada, dadi. They go home and tell everything, they blabber. So easy to prepare the community like that. One. Two, as you correctly
Yeah.
mentioned, the ambulance services. We are
Yes.
still lacking in ambulance services standard, and
Yes.
there is no regulatory authority around it. How to structure the ambulance, who goes inside the ambulance,
Yeah.
all those things. So again, you are dependent on who comes to rescue you, and if you can't rescue, you should scoop and run. That with that aim, the 108 was built and run in many of the states, but some
Yeah.
states are still missing out and they've got their own numbers. There are varieties of numbers to call
Right.
an ambulance that needs to be universalized. Then comes the third part is an ambulance, or the emergency department, which has to be structured and manned by the trained people. So getting the training of emergency doctors, we started very late in compared to other part of the world. 2009 we started MD program in emergency medicine, and 2014 we started DNB
Yeah.
emergency medicines. Pretty new concept, Till then, other university training program were happening in our country, and they still happens because we need a lot of emergency doctors, and that's how we can be emergency ready. We have got a lot of people who build the beautiful hospital, fantastic structures, equipments, and if we build the coordinated approach or the structure around it the way NABH and JCI wants us to, and follow it full hearted, we can save a lot of lives.
It will also improve the reputation of these organizations as well, because that will help them build that credibility also inside the society, inside the geography in which they are operating.
If you are in five-star hotel and you get the guest, the serving is going to be different, like the same thing. But what do we need? We need to identify first
Yeah.
response has been given, the water has been given, tea has been given, all has been given, and they are saved. They are not
Yeah.
hungry, they are not starving to the death.
Yes.
If they want, they can go to the five-star and get the same thing, the water and the tea and the basic food. But if you
Right.
can't, if you don't have water and tea, you should be able to tell them, I don't have
Yes.
water and tea, please don't come to my hospital. I cannot serve the trauma, I cannot do cardiac, I
Yes.
cannot do stroke, don't bring the patient here. How many hospitals are ready to say that? If they don't say I don't have, they should publish what they have. Okay, so they should
Right.
publish that we are the stroke ready hospital. Now we get the
Right.
certification as well that these are the stroke ready
No. Yes.
hospital assessed by American Heart Association, and they can give you
Yes.
the cardiac
Yes.
and stroke care and trauma care. All those things can be given to the hospital, major hospitals, so people around and the nearby hospitals know when to transfer the patient to those hospital
Yeah.
in a coordinated manner. And that's how, even if you are small hospital who is catering to different variety of
Yeah.
diseases of the community, to offload the major hospital, but when it falls beyond your reach, you should transfer that patient
Right.
on time to the major hospital who can provide those care. And that's the only way of, we need small clinic, medium clinic, bigger clinic, hospital, tertiary care hospital. We need a whole thing, but everyone should know their limitation, and then only, and people should not go to their doctor because they know them. They should go to the place which can give them treatment. So that's how, if people are
Yeah.
aware, they can do that. If they are not, they will end up, because the faith is not there. That's why they avoid certain things, and that's where they fall in the trap as well.
No, this is so well said, ma'am, because I am yet to see a hospital in India which is very clear about what they don't do. What they do, they discuss it out in kind of details.
Yeah. Major hospitals and clinics who has undergone those authority inspection, they will have those structure. The rest will not have, who doesn't require to have, because they are not reaching to those that sick patient, but they will have a walk-in sick patient, and that's where they have to play that part at that point of time.
Yes.
Attack in Australia also, I saw the disaster. They are all next door. So evolving, we have evolved a lot from zero. We have reached to the NABH with a structured emergency department, standardized protocol, which gives an hospital an opportunity to look into that window of what all they should do. Because right now, many organization focuses on quick recovery of their investment, and that's where they fall back with the trauma, with MI, with the stroke. Walking into their hospital with the faith that this hospital will give me the care, they fail there because the structure of emergency is not there. They have got the best doctors available, but they are not coordinated from the emergency, and that's where they fall on the face. Emergency is the face of the hospital. Emergency has been standardized, protocol has been given by NABH and JCI, which needs to be tapped upon by all organization and their CEO and whosoever is their authority or owners. They should be aware that they are the face. If they need some emergency, if they need some care in during their own emergency or family member emergency, even if they call, it will take 10 minutes, 15 minutes for that doctor to reach to the hospital, and they reach to the hospital. If they coordinated, if they with all standardized protocol and structure, if they tap and develop the emergency, we can do wonders. Developing the emergency is like clearing your face and showing the people what you can offer when you are in the serious situations. So hospital has to reach out to the nearby community. Nearby small hospitals and clinics needs to be handholded by those major hospitals, and that can be easily done. And that's how you can have a coordinated approach with people who needs emergency care. That can be built upon. It's not like a difficult task. It has been done in major cities, and it is still getting done. So it's evolving very fast. India, once we see the small light of ray, we actually open it up fully. So we have got that potential, and we can do wonders in the emergency as well. So from we have got airlifting, we have got train also, boogie, who carries the first aid and kind of hospital services for the long trains. So a lot of things have been done by the government, by the major corporates, by the regulatory authorities. So it is evolving very fast, and I'm sure our future is bright, because from the small clinic to the GP clinic to the nearby hospital to the tertiary care hospital or major government hospitals, we have lot to offer, and very quick response we do get.
Hey, thank you so much, Dr. Dina, for joining us on this podcast and sharing all these insights with us. Extremely kind of insightful, and we look forward to more and more organizations, both healthcare as well as non-healthcare, to understand the importance and make sure that these things are kind of implemented so that we can build a better society, we can build a more productive society. And once people are more productive, once people are more secure, it also adds to the GDP of the country as well. So emergency response systems in a way directly affects the GDP growth rate of any economy. And if every
Absolutely.
company and every organization understands this importance, trust me, your organization's revenue will grow by X percentage, and that X will depend on how sincerely you adopt such practices. Thank you so much, ma'am, for joining us and taking out time for sharing these insights. We'll put the LinkedIn link of Dr. Dina
Appreciate it.
Shah, yeah, in the description. So kindly reach out to her for any guidance that you need in terms of emergency readiness preparation and the related stuff. And I've been in touch with ma'am for the last 2-3 months now. So the kind of passion that basically shows and has taken this up after a prolific career is heartwarming, and we look forward to supporting her her, to kind of make this vision fulfilled as much as possible. Thank you so much, ma'am.
Thank you, Rishikesh, for providing me this platform to speak on emergency, my vision, my passion, and happy to help any organization who needs care or development. We do that only. So thank you again. Thank you very much to the team Diddle. Thank you.